Good afternoon, everyone. I'm here to present a challenging case. So this was a 24-year-old doctor with perfectly normal preoperative topography and normal indices. When we came to the case history, she had a past history of dust and pollen allergy, and as well as she was on nutritional supplements for deficiencies. There was no significant systemic illness. She underwent an uneventful smile surgery with an unremarkable early postoperative recovery as well. However, she presented 5 years post-surgery with ectasia, so what could have possibly gone wrong? Could this have been predicted? Could this have been prevented? What could have been the contributory factors? So does inflammation play a role over here? So recent literature has shown the presence of increased corneal dendritic cells and altered tear cytokines to suggest an inflammatory response in PLE. So this was what her confocal looked like, wherein there was increased dendritic cells, which suggested an undergoing inflammatory response. But was there also another hidden clue on the confocal? Yeah, so these are the healthy corneal nerves post-smile surgery, and you should see in the two pictures lower down, you see poor nerve regeneration with increased dendritic cells in the post-smile ectasia. Is there also another way to assess the inflammatory response? So what could have possibly done was her tear film levels could have been assessed prior to the surgery, but we anyways did it post-surgery when she presented to us. So tear collection was done using Schirmer strips, and then using our patent buffer and the customized biomarker cartridge, we did an ELISA 90-minute assay, and we found that her MMP9 levels were elevated along with increased pro-inflammatory interleukins in the tear fluid. So all this suggests an undergoing inflammatory response. And is there any other factor which is not discernible on conventional imaging? So this is where PSOCT comes in, which is polarization sensitive OCT, which indirectly maps the collagen fibril orientation. So this is a reference image of a normal eye wherein you see densely packed, the more amount of blue shows you densely packed collagen fibrils located centrally, while the picture on your right, it shows you sparse distribution of the collagen fibrils or a loss of checkered arrangement suggestive of ectatic eye. So could genetic predisposition also contribute to the ectasia? So epithelium was collected from the area of ectasia, and a qPCR analysis was done. And we found reduced levels of LOX, which indicates a predisposition of the healthy eye to develop ectasia. So this has been our previous published work, wherein we found that bilaterally asymmetrical corneal ectasia following smile with asymmetrically reduced corneal stromal molecular markers. So post-smile ectasia with a seemingly normal preoperative topography, what are we possibly missing? So number one is factors which suggest an inflammation. So a history of eye rubbing is important. Elevated tear cytokines, increased dendritic cells on the confocal. Of course, poor nerve regeneration, loss of checkered arrangement of collagen on the PSOCT, reduced expression of LOX contributing to corneal strength and integrity, and other contributory factors could have been increased intraocular pressure or poor wound modulation. So what could have been done differently, or if we could have possibly gone back in time? So counseling for eye rubbing, blood levels of vitamin D and Ig should have been done, targeted levels for biomarkers based on our kit, and increased LOC expression due to inflammation control. So trehalose we have known that trehalose augments autophagy, and it reduces the inflammation in the corneal cells. This is a normal reference image of the PSOCT, and you can see the cornea, how the collagen arrangement looks like pre-trehalose and post-trehalose. So how does one avoid potential cases of post-smile ectasia? So a good preoperative control of inflammation based on your clinical history, ocular surface, tear biomarker levels, confocals, and an analysis of the genetic markers. You need to optimize the structural integrity, informed choice of surgery, and post-operative monitoring and control. Thank you for your kind attention.
So how did you manage this case?
So, sir, her ablation, if we could have planned a TPRK for her, the ablation...
Whatever has been done.
We did a trek with a KXL, sir, for her, because it was a centered cone, and trek allows you to ablate 20 microns of the stroma, which would have been ideal because it was...
Followed by cross-linking again.
Yes, sir. Followed by cross-linking.
How do the panelists does it really work?
Yes, ma'am. Yes, ma'am.
I don't think so.
That's why I wanted to ask, is everybody using trehalose post-operatively?
I'm basically a glaucoma surgeon and I do a lot of work in ocular surface as well as cataracts. And they all came along and how the dealers say that, Trehalose is fantastic. And so we say, okay, let's try it. And I found that, patients say, no, 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 it doesn't work. So when patients say, no, 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 it doesn't work, then you say, okay, take a back seat because it's expensive. So you have to think twice before. That's why I want to know from the panel. Okay, how do you find Trehalose?
So, ma'am, Trehalose is actually not just a lubricating drop. It's a sodium hyaluronate based drop, and in that they've added mannose 6-phosphate. It acts as an autophagy inducer. So, in keratoconic eyes or in any post-LASIK ectasia or such inflammatory eyes, your MMP9 levels are extremely higher, and the eyes are under a tremendous oxidative stress. So when you give Trehalose for 4 times in a day for 6 months at least, we have seen a lot of patients, not only they stay stable, but they flatten, actually without doing a cross-linking. So the idea here is that it's not just an artificial tear or a lubricating drop, but we do explain to all our patients that this we are not giving as a treatment for your ocular surface or dry eye. We are giving this because it has an evidence that it can keep your eye stable, especially when you have keratoconus or a post-LASIK eye.
These are only 2 conditions you talked about. But what about inflammation, what you're having in cases of ocular surface diseases? Most of us know that you've got, that's why your MMPs have come up. So then what about them?
So in ocular surface conditions, ma'am, it's not just the MMP9 which comes up. There are many other markers which come up. But at this, so we are working, as she suggested, on a kit which will have multiple markers. But it will take another 1 or 2 years for it to come to clinics and for the clinicians to start accepting it. But at this point of time, you do not have it. So Trehalose alone is not the answer, I agree. In ocular surface conditions, you do have to give other drops as well.
Yes, I agree. That's exactly. That means you need something else in the dry eyes which you are getting for whatever reasons, because we know that there's a large amount of inflammation taking place in dry eyes for whatever reasons.
See, most of these patients, my simple observation is you'll end up in such cases where you have ectasia. You don't want to wait for an attempt dose Trehalose or any anti-inflammatory substance for that matter, although you notice difference after 6 months as you claim. But the thing is, would you like to wait and do the same treatment in these kind of patients? Where, then why attempt TREC and do cross-linking in those patients immediately?
So this is a post-smile ectasia eye. This patient definitely requires a cross-linking. There is no question to it. But as she is an ophthalmologist. Actually, I'm not sure whether we mentioned, but she herself is an ophthalmologist, and she was absolutely fine 6 months back, and she's developed ectasia within 6 months. And
how long post-op is she now? Like
5 years. So within 6 months, if she has developed ectasia and in such advanced ectasia, it means there is something going under, and that is the sign of inflammation. No eye rubbing, but yes, her OSDI score was 72, and that is why we kept her first on Trehalose to reduce the inflammation. Otherwise, if we do a surgery, she can land up in excessive scarring or infiltrates. So just to avoid it, we wanted to reduce the inflammation. That's why we give Trehalose and then took her up for surgery. Ma'am, cyclosporin can also be given in this case, but she was, I think, not in the favor of using cyclosporin. No, ma'am. It's extremely surface irritant, and the effect what you get with Trehalose alone is much better, and patient satisfaction is much better there compared to tacrolimus.
Any patient of keratoconus, Trehalose is your normal regime?
We give post-operatively all our patients Trehalose because the epithelial remodeling is much, much better in keratoconic eyes. So all our keratoconic patients, when they undergo cross-linking, whatsoever cross-linking, we do give them Trehalose.
Even without cross-linking?
Without cross-linking also. If it's grade 2 or higher. If it's grade 1 or FFKC, we do not give.
I give cyclosporin plus Trehalose. I think
We give both, but it's not mandatory. But as a lubricant, we do not give any normal lubricant. Lubricant is in the form of Trehalose.
Are you recommending Trehalose?
It's up to you, sir. If the patients have complaints of ocular surface inflammation or dry eye, you can give.
For prevention of deterioration?
It's an overkill from first keratoconus. But if panelists can decide, Correct me if I'm
I
wrong.
think, you know, unless you've actually documented the, you know, inflammatory markers and everything in detail, and I mean, in your kind of case that you've said, because otherwise, as she said, it would be an overkill, huh?
It's not possible for us to.
Exactly. So that's why, I mean, that's exactly what in fact, I was going to ask you, since you said that your recommendation was that in all SMILE patients do a workup for all the markers and everything, and 99% of us won't be able to do that. So, you know, in your setting, it does work. But for us, you know, when we talk in the meetings, we have to talk about what works for most people.
I
And
think,
for that,
yeah.
I think we have all the set parameters. So but it's good to know, because, you know, then we can kind of, people can plan what else needs to be done in the future, I think. So in that sense, it's very nice. Thanks.
Thank
I
you.
think-
Sir, I have a question.
Yeah.
Since this case had an ectasia which came up in 6 months' time and was stable for 5 years post-surgery, you also mentioned that she was on dietary supplements for some deficiencies. So whether we need to look beyond the eye, because there was a high inflammatory response in the eye, so whether it was any other systemic deficiencies or whether there was any hormonal change, because that could be one contributing factor in an eye which is stable for 5 years, and why will the ectasia come up in 6 months if it is just an ocular surface inflammation? So whether there are any systemic factors, it could be B12, it could be B9, it could be a vitamin D3 deficiency which needs to be worked up in this patient.
Absolutely right, ma'am. I agree to that. But a detailed history for her systemic illness was also taken up, and she did, like before we planned the surgery, she did get a physician checkup done as well.
So
So I think important point highlight